My name is Neelambuj Regmi from Wayne State University, Detroit Medical Center. Today I'm going to present my poster titled Heme-Pigment Induced Acute Renal Failure in a Patient with Paroxysmal Nocturnal Hemoglobinuria. I'll first start with the introduction of Paroxysmal Nocturnal Hemoglobinuria, in short PNH. PNH is an acquired hematopoietic stem cell disorder. It is a rare disorder with a reported incidence of 1 to 10 cases per million population. Vast majority of the cases are associated with mutation of PIGA, which is a gene on X chromosome. PNH has an unusual constellation of clinical findings. It is classically associated with a triad of hemolytic anemia with pancytopenia, thrombosis, and hemoglobinuria. Now let's go to the case. So our patient is a 34-year-old lady with a past medical history of alcohol use disorder and a recent diagnosis of PNH. She presented with fatigue and generalized abdominal pain. She had also noticed yellowish discoloration of her skin, her eyes, and also noticed dark urine in the last few days before presentation. Examination including vitals were normal at the time except for scleral icterus and a generalized abdominal tenderness. Labs were consistent with hemolytic anemia and acute kidney injury with a low hemoglobin of 10, a low haptoglobin of less than 30, increased LDH of 3000, increased total bilirubin of 5, and increased indirect bilirubin of 4.5. She also had increased creatinine of 11 and increased BUN of 45 consistent with her AKI. Her diagnosis during the previous admission was confirmed with a flow cytometry, which was positive for PNH. During her admission, her renal function did not recover, ultimately leading to a renal biopsy showing acute tubular necrosis with intratubular hemoglobin cast, which can be seen as dark brown pigment in the pathology slide, which is suggestive of intravascular hemolysis and hemoglobinuria. She required hemodialysis for acute renal failure and received eculizumab during the hospital stay after receiving appropriate meningococcal vaccination. She was on outpatient hemodialysis for 4 weeks after initiation of eculizumab, after which her kidney function recovered and she is now currently off hemodialysis. So our case is interesting in the sense that PNH itself is a very rare diagnosis. Also, acute kidney injury in PNH is a rare finding, even though there are several ways that the heme pigment can injure kidneys. It mostly injures kidneys by tubular obstruction, but can also do it by direct proximal tubular epithelial cell injury as well as vasoconstriction, leading to reduction in the blood flow in the outer medulla. There are only few previously reported case reports where there was a patient with AKI resulting from heme-pigment deposition, which was proved in our patient with the help of kidney biopsy. The management of PNH mostly involves either allogenic hematopoietic cell transplantation or complement inhibition with eculizumab. Importantly, however, anti-complement therapy with eculizumab, as in our patient, do not modify the underlying hematopoietic stem cell defect responsible for PNH. Thus, they are not curative and they must be administered continuously to be effective. This concludes our presentation. Thank you.